When a man receives the unsettling news that he has prostate cancer, he suddenly enters a world with terms like rising PSA, active surveillance, and Gleason score. Hi everyone, my name is Dr. Howard Lewine. I'm an assistant professor of medicine at Harvard Medical School and a senior editor at Harvard Health Publications. In this brief video, we will be speaking with Dr. Marc Garnick, Gorman Brothers Professor of Medicine at Harvard Medical School and Editor-in-Chief of Harvard's annual report on prostate diseases. Dr. Garnick will preview research he's studying for the 2016 report and will offer key questions what you should ask your doctor if you've received a cancer diagnosis. The Harvard report will also cover other prostate conditions, such as prostatitis and enlarged prostate. But first, Dr. Garnick will describe top developments making news this year in prostate cancer research.
There are many among the top three as the increasing use of active surveillance. Men who have been diagnosed with prostate cancer who do not necessarily need to undergo active therapy at this time. And we're now using genomic testing to help identify those patients that may not necessarily need immediate treatment. So that's one very, very important aspect. The entire use of so-called biomarkers to help determine what the biological behavior of an individual's cancer will be. And the third most important aspect is there are a whole series of not only new drugs, but actually older drugs that have been used in earlier stages of the disease. So for example, there's been a lot of press coverage about the use of chemotherapy in a small subset of fit men who happen to present with advanced forms of prostate cancer. In the past, chemotherapy has been used in later stages of the disease when patients had gone through multiple types of treatment. Now the potential use of chemotherapy earlier in patients that have advanced forms of disease may be very, very important. Well, very important question. And the critical component of any therapy for prostate cancer is, does it improve patients' lifespan, does it increase patients' lifespan, and does it actually decrease the likelihood of a patient dying of prostate cancer? And against that, one has to balance the side effects of therapy. So unfortunately, from the large screening studies, we have very, very little information that any of our interventions in patients that have so-called screen-detected cancers actually makes them live any longer. That's been the major dilemma in prostate cancer therapies so far. So now, the fact that a patient has prostate cancer oftentimes prompts the patient wanting to get treated. And we now have the concept of so-called overdiagnosis and overtreatment. Number one, did that cancer need to be detected in the first place? And even if it was detected, does that cancer need to be treated? And so a large number of patients with prostate cancer who are diagnosed every year fit into those categories. So instead of whisking that patient off to either receiving surgery or radiation therapy, we're now taking the action of what we call active surveillance. The diagnosis has been made. We look at certain clinical and pathological and now genetic characteristics of that cancer, and we can say, the likelihood of your cancer progressing or the likelihood of your cancer causing symptoms, or more importantly, the likelihood of your cancer killing you over your lifetime is extremely small. And so we could potentially balance not treating that cancer, but continuing to watch it very carefully and then intervene if there's some degree of disease activity that indicates that the cancer is more active than we thought it was. So we now take patients that have been diagnosed with prostate cancer and look at a variety of characteristics: what the cancer looks like under the biopsy, what the cancer feels like on digital examination, what some of the screening staging studies look like. And we can say with pretty good certainty that your particular cancer does not necessarily need to be treated, and rather we can watch it carefully and do active surveillance with periodic repeat digital examinations, repeat PSA examinations, and periodic repeat biopsies, and then determine what the activity of the cancer is. And a large proportion of those patients who are diagnosed who don't get treated never ever need treatment. By far, the several most important questions are, number one, did my cancer need to be diagnosed in the first place? Okay. And if so, What is the extent of my cancer? Is the cancer localized to the prostate gland, or have any of the other studies looked at indicate that the cancer is spread elsewhere? That's by far the most important aspect. Secondly, does my cancer need to be treated? And if so, what are the side effects of various forms of treatment? Is it going to change my lifestyle? Is it going to impact my ability to urinate? Is it going to affect my ability to have sexual activity with my spouse? Very, very important. Those side effects are critically important. And the third is, if I get treated for prostate cancer and the cancer comes back, what happens then? So I think those are the three most important aspects. Did the cancer need to be diagnosed and if so, did it need to be treated? What are the side effects of treatment if I decide to undergo therapy? And if I get treated and the cancer comes back, what's happening at that point?
Thanks, Dr. Garnick. If you would like to learn more, you'll find a link to the 2016 Annual Report on Prostate Diseases at health.harvard.edu. For Harvard Health Publications, I'm Dr. Howard Lewine. Thanks for watching.